Okay, so thank you for all of you that have joined, and we're very honored today to host Dr. Sam Okpaku, who's presenting to us from Nashville, Tennessee, and he's the founder of the Center for Health, Culture, and Society. In addition to being this week's Grand Round speaker for Harbor UCLA Department of Psychiatry, I also want to acknowledge that this presentation is co-sponsored by UCLA's Health Equity and Translational Social Science, or HETS, research team as part of the David Geffen School of Medicine at UCLA. And we're very glad to co-sponsor this with them. A little bit about our speaker. Dr. Okpaku completed his medical degree at the University of Edinburgh in Scotland, his PhD in social research and welfare from Brandeis University. He trained in both internal medicine and psychiatry. He's a fellow of the Royal College of Physicians Canada, a fellow of the Royal College of Physicians in Edinburgh, and a lifetime distinguished fellow of the American Psychiatric Association. He's had a long and distinguished academic career, having served at various points as currently clinical professor of psychiatry. At various points, clinical professor of psychiatry at Vanderbilt, senior fellow at Vanderbilt Institute for Public Policy. He was chair and professor of psychiatry at Meharry Medical College, past president of the Black Psychiatrists of America, and currently clinical professor of psychiatry at George Washington University in Washington. So his research interests have been diverse, including depression, psychotherapy, drug abuse, disability reduction, participation in SSI and SSDI programs, and cultural psychiatry, cross-cultural psychiatry, with considerable academic publication and accomplishment in these diverse areas. His primary current interest is in global mental health, and he's had a number of books and articles in the area, including Mental Health in Africa and America Today, Clinical Methods in Transcultural Psychiatry, Essentials of Global Mental Health, and Innovations in Global Mental Health. His current project is a multidisciplinary training handbook on global mental health. He served on boards such as Metro Nashville Board of Health, has been the recipient of several awards nationally and internationally, and is an internationally recognized leader in global mental health and a critical thinker in the ethics, dynamics, and implementation of global health programs. So with that, we're honored, and Dr. Okpaku, I turn it over to you.
Well, Michael, many thanks, many thanks. I think it's a privilege for me to be addressing your group today. It's taken Ethel, Elena, a lot of work to get me here. In January this year, on a Wednesday, I had packed my bag because I was due to give a lecture to UCLA on the Friday. So at about 3 o'clock in the afternoon, my plane was to leave at about 7 o'clock. I called a good friend of mine, Benedict Grushen, if I should come to Los Angeles. She said, definitely no. That was probably the best decision I ever made in my life. So I appreciate what Michael, Ethel, and Elena are doing. Also, I want to extend my sympathies to individuals, faculty, and families who had some consequences from the Los Angeles fires. I think one of our colleagues, David Barron, lost his home, and it was a pity. So I'm glad to see you all. And so my topic today will be reflections on ethical and humanitarian concentration in global mental health. Since we're talking about Nobel Prize, I'm going to read for you an excerpt from Kofi Annan, who won the Nobel Prize in the year 2001 in association with the United Nations. Kofi Annan said, "Your Majesties, Your Royal Highnesses, Excellencies, members of the Norwegian Nobel Committee, ladies and gentlemen, today in Afghanistan, a girl will be born. Her mother will hold her and feed her, comfort her and care for her, just as any mother would anywhere in the world. In these most basic acts of human nature, humanity knows no divisions. But to be born a girl in today's Afghanistan is to begin life centuries away from the prosperity that one small part of humanity has achieved. It is to live under conditions that many of us in this hall would consider inhuman. I speak of a girl in Afghanistan, but I meant equally well I've mentioned a baby boy or girl in Sierra Leone. No one today is aware of this divide between the world's rich and poor. No one today can claim ignorance of the cost that this divide imposes on the poor and dispossessed, who are no less deserving of human dignity, fundamental freedoms. Today's real borders are not between nations, but between powerful and powerless, free and fettered, privileged and humiliated. Today, no walls can separate humanitarian or human rights crisis in one part of the world than national security crisis in another. Scientists tell us that the world of nature is so small and interdependent that a butterfly flapping its wings in the Amazon rainforest can generate a violent storm on the other side of the earth. This principle is known as the butterfly effect. Today, we realize, perhaps more than ever, that the world of human activity also has its own butterfly effect, for better or for worse. Mary, so what is ethics and what is humanitarianism? Albert Camus said, a man without ethics is like a wild beast loosed upon the world. And Immanuel Kant said, act in such a way that you treat humanity, whether in your person or in the person of any other, never merely as a means to an end, but always at the same time as an end. I belong to the Caucus for Global Health at the APA, and we are struggling with being neutral. What is it to be neutral? What is genocide? And so on. So the world has become very highly polarized, but we have to trust in continued humanity. I'd like you to take a look at these graphs. These are two programs generated by Google called Google Books Ngram Viewer. Apparently, Google is able to track the frequency of usage of some words or phrases. The top one is for ethics, and the bottom one is for humanitarianism. You see, they parallel each other. And you see that when there are spikes, it has to do with world events, like the Second World War, or the Holocaust, or the Pakistan floods, or the Nigerian Biafran wars. I would think that this parallel distribution will continue and even grow further as we talk about the war in Ukraine, the war in Gaza, and other human crises, climate change, and so on. So what is ethics? Ethics can be defined as the rules of behavior based on ideas of what is good or bad. And there are many schools and theories of ethics. This is Peter Singer. Peter Singer is an Australian who studied at Oxford and became converted to animal rights. He says that ethics is not a matter of factual knowledge in a way of the sciences and other branches are. Rather, it has to do with determining the nature of normalizing theories and applying this set of principles to practical moral principles. Mary?
Go to them, yeah.
Yeah.
Stay in that one.
This is the center of one of the world's richest countries and one of the most expensive places there. And that raises an ethical issue. I mean, there are people who have the money to buy at these stores and who don't seem to see any kind of moral problem doing that. But what I want to ask is, well, shouldn't they see some sort of moral problem about that? Isn't there a question about what we should be spending our money on? So we're outside Bergdorf Goodman, where they've got a display of Dolce & Gabbana shoes. And it's kind of amusing to me because about 30 years ago, I wrote an article called Famine, Affluence and Morality, in which I imagined that you're walking past a shallow pond, and as you walk past it, you notice that there's a small child who's fallen into the pond and seems to be in danger of drowning. And you look around to see where the parents are, and there's nobody in sight. You realize that unless you wade into this pond and pull the child out, the child is likely to drown. There's no danger to you because you know the pond is just a shallow one, but you are wearing a nice pair of shoes, and they're probably going to get ruined if you wade into that shallow pond. So, of course, when I ask people this, you know, they always say, well, of course, forget about the shoes. You've just got to save the child. That's clear. And then I stop and say, okay, well, I agree with you about that. But for the price of a pair of shoes, if you were to give that to Oxfam or UNICEF or one of those organizations, they could probably save the life of a child, maybe more than one child in a poor country where children are dying because they can't get basic medical care to treat very basic diseases like diarrhea or whatever else it might be. And that's really one of the reasons why I think it's interesting to be here on Fifth Avenue talking about ethics, because ethics is about the basic choices that we ought to make in our lives. And one of those choices is, how do we spend our money?
It may appear to be so simple. It's not that simple. Last Friday, I took some Thai food to the father of a student who worked for me many years ago. He's just been discharged from hospital. And in conversation, I made reference to how obscene it would be to own a yacht of $100 million while people are starving. And he seemed to have taken objection to what I said. So I reminded him of two things in the Bible. Love your neighbors as yourself, or am I my brother's keeper? You know. So these issues of ethics and so on is not that easy. And sometimes some philosophers will look at ethics in terms of morality. What are the sources of ethics? The sources of ethics may be values, beliefs, principle of values. Some people believe that ethics may come from culture, traditions, and religion. Are ethics static? Thou shalt not kill. That's an ethical principle. But every day in the news, people are being killed. Children are being murdered. Women are being killed in war zones and so on. There's been a historic perspective on ethics. You recall that in 1972 to 1974, there was a Watergate crisis when some assistants and subordinates of Nixon invaded the Washington headquarters of the Democratic Party, and several lawyers went to jail. And then there was Enron, the big energy company in Houston that that in 2001 had the largest bankruptcy case. And then on the European side, there was the Parmalat, a dairy company that did worldwide fraudulent accounting. So, as I said, ethics are not static in terms of autonomy versus individual choices and decisions that individuals make versus autonomy. Even in the United States, an issue like end of life decision in some cultures is entirely individual, and in other cultures it's a family decision. And as I said before, ethics can be seen as an exploration through reasoning as to what is right or wrong, or bad or good, whilst morals is practice of rightness or wrongness of an individual's group's decision. There are many frameworks of ethical principles. As I said before, are they universal? Are they specific? Thou shalt not kill. But there are four basic cores in ethical principles, and these are autonomy, the ability to make decisions for oneself, beneficence, promote the well-being of people, non-malfeasance, principle of do no harm, and then the principles of justice, social stability, interdependence, and equal dignity. Now, various professional groups or disciplines have their own ethical guidelines. This is significant because in terms of international health or global health and so on, it tends to be multidisciplinary. So social workers may have a different code of behavior than nurses. Case managers may have a different one than nurses or physicians. Case managers add to the primary central codes veracity and fidelity, and nurses accountability. Different religious groups or cultures have different principle guidelines. One of the most famous one is the Hippocratic Oath, but you also have the Jewish one, you have the Buddhist one, the Hindu one, Japanese one, and so on. The most popular is the Hippocratic Oath, and it is interesting that there's an overlap of central cause between these guidelines. There seems to be an acceptance or honor to a supreme being. There's also a regard and thankfulness to teachers, and there's respect for human life. And it's interesting that in several of these guidelines, they make references to abortion, which I thought was interesting. Take the Hippocratic Oath, for example. I swear by Apollo the physician and Asclepius the surgeon. And I will use my power to help the sick to the best of my ability and judgment. I will abstain from harming or wrongdoing any man by it. I will not give a fatal draught to anyone if I'm asked, nor will I suggest any such thing. These may have implications for end-of-life decisions. It's interesting that many of the principles are derived from Buddhist oaths. The Buddhist oath of practice has 6 main articles. 1, that the physician is trained to properly dispense drugs. The physician should never harm a patient. He is to care for all of their patients and to put the patient's well-being above their personal gain. The physician must not humiliate the patient. That is very important. Spiritual counseling has a role in healing, and it is important that physicians have some knowledge in this area. The physician must not give up on care for the patient, even if the patient is not responding well and may die. So as I said, all these guidelines have a major overlap. Take the Hindu oath, for example. The teacher then should instruct the disciple in the presence of the sacred fire. Thou shalt lead the life of a celibate, grow thy hair and beard, speak only the truth, eat no meat, eat only pure articles of food. The student should be completely obedient to their teacher. If the student wishes success, they should prioritize the health and well-being of all living beings, which implies some equality and generosity. The student must do all they can to treat the patient and live a life free of sin. There's an Islamic one that says a prayer to Allah for the well-being of the physician and the patient. Praise be to Allah, the teacher, the unique majesty of heavens, the exalted. So there's a superior being which is exalted. The Japanese, each person should follow the path designated by heaven. Buddha, you should always be kind to people. You should always be devoted to loving people. The teaching of medicine should be restricted to selected persons. You should not tell others what you are taught regarding treatments without permission. Another very common item is confidentiality. The Jewish religion seems to have two. One is the Asaph and the other is the Maimonides. Maimonides says, Almighty God that has chosen me to watch over the life and health of the creatures. I'm now about to apply myself to the duties of my profession. Support me in these great labors that they may benefit mankind. For without that help, not even the least thing will succeed. So ethical principles can be classified into some theories: the normative, the meta-ethics, applied and the descriptive. The normative consists of the consequential, focuses on consequences of actions. So I'm a captain and one of my men has been killed. Do I go to a village and kill 50 million people because of that one fact? Or deontological, what's my duty to save lives? Or virtue, what should I do to be regarded well? Meta-ethics is philosophical, and then there's applied and descriptive ethics. So what is humanitarianism? Humanitarianism basically is a promotion of human values or human welfare. The beacon of this is the Red Cross that was formed in 1858 by a Swiss businessman called Dunant. The world has always been oriented by the code of humanitarian ethics from the Red Cross. Some of the important aspects of the code are that the humanitarian imperative comes first. Aid is given regardless of the race, creed, or nationality of the recipients, and without adverse distinction of any kind. Aid priorities are calculated on the basis of need alone. It goes on to say, ways shall be found to involve program beneficiaries in the management of relief. This Swiss individual was a businessman and was traveling in Italy when there was a battle between Italians and Austrians who wanted to take some part of Italy. The Italians were being supported by the French. And he was the first person who saw the need for an organization to take care of wounded soldiers initially. And he was the first person to win a Nobel Prize for peace. Meanwhile, though, he ran into some business trouble, became very poor, and was later rediscovered by a journalist, and that was when he won the Nobel Prize. According to that code, it says, in our information, publicity, and advertising activities, we shall recognize the set of victims as dignified humans, not hopeless objects. Meanwhile, there's a new paradigm in terms of what the Red Cross has in mind. With the classical humanitarianism, the emphasis was on short-term crisis intervention. Local leaders were sometimes treated with distrust and sometimes ignored. With the new paradigm, the resilience paradigm, there's a unification of relief to rehabilitation and to development. Locals are first responders, and there's an attempt to build on capabilities and strengths of the local. And excuse me. Excuse me a second. I'm sorry, that was spam. With the new paradigm, the resilience paradigm, there's unification of relief to rehabilitation and to development. Locals are first responders. There's an attempt to build on the capabilities and strengths of the local. It is perceived that the resilience paradigm is more relevant to modern situation. You all recognize this. This table is a table that depicts the disability. The burden of disease worldwide. You see that neuropsychiatric disorders amount to about 13%. HIV is 6%. Okay. However, you will agree that whenever we are not 100% physically well, there's corresponding psychological component. So how do we apply our basic knowledge of ethics? And what is the statement of the problem in terms of global health? Some items of global health include the fact that low and middle income countries account for about 80% of the world's population of 6.7 billion. Worldwide, 450 million people are affected with mental, neuropsychiatric, and neurological disorders. This percentage may be higher now that there's increased anxiety and depression in society and a lot of economic uncertainties. 25% of individuals will suffer the above conditions sometime in their lifetime. Mental and neurological conditions contribute 14% of the global burden of disease due to non-communicable diseases. It is estimated that by 2030, unipolar disorder will rank the second leading cause of death. There's increased interest in increased pathology in youth and young people with suicide and so on. About 70% of African and 50% of Southeastern Asian countries develop less than 1% of their health budget on mental health. The treatment gap of mental, neuropsychiatric, and neurological disorders is great in low and middle income countries. Investigators from low middle income countries carried out less than 14% of the clinical trials for new mental health interventions. Research related to publications in prestigious journals is disproportionate. So clearly, if you're interested in global mental health, you begin to think about possible ethical implications of all this. And so there was the Millennium Development Goals that were set up in 2000, when about 189 members of the UN signed the agreement to end poverty and hunger, provide access to universal education, promote gender equality, promote child health, promote maternal health, combat HIV/AIDS, promote environmental sustainability, promote global partnerships. As you know, Kofi Annan was involved in this, and it is almost a miracle that some of the items could be approved. For example, number 3, promote gender equality. This was not very pleasant to certain leaders with certain religious backgrounds. There's a report card on these Millennium Development Goals. In some areas, there's been some improvement. For example, education of women. In some other areas, there's been no change. And in fact, there may be some worsening. Following the Millennium Development, by the way, the Millennium Development Program was for only certain countries in Asia, South Africa, and certain poor countries in Central and Eastern Europe. And then came the Sustainable Development Goals that was signed in 2015. These had 18 goals: no poverty, good health, quality education, again, gender equality, clean water and sanitation, industry innovation infrastructure, sustainable cities and communities. So you see that issues like climate change are becoming more important: climate action, lifeline, life below water, peace and justice, and strong institutions, partnership goals, and so on. Following on that, you have the increased interest in the fact that non-physical health issues can be determined by social factors and other parameters. So you have the social determinants of health, including adopt improved governance for health and development, promote participation in policy meetings and implementation, further orient the health sector towards promoting health and reducing health inequities. That's a central issue. Strengthen global governance and cooperation, monitor programs and increase accountability. So in terms of our definition of things, what is globalization? There are multiple definitions of globalization. It's like when you talk about culture, you talk about 200 and something definitions of culture. But the one I prefer the most is Giddens, who says in 1990 that globalization is intensification of worldwide social relationships, which link distant locations in such a way that local happenings are shaped by events many miles away and vice versa. So you have Michael Jackson dancing in Los Angeles in 1 minute, and in the next minute you have some people in Japan doing the moves. Now, global health can be defined as by Copeland, who was a director of CDC, as an area for study, research, and practice that places a priority on improving health and achieving equity in health for all people worldwide. Global health emphasizes transnational health issues, determinants, and solutions. It involves many disciplines within and beyond the health and sciences and promotes interdisciplinary collaboration, and is a synthesis of population-based prevention with individual-level clinical care. So that was the basic definition for global health. And Patel and Prince adopted that by just substituting mental health for health in Copeland's definition. Many years ago, I was at a conference at Yale, and there was a young man who came in, a medical student, and he said he performed surgery, cardiac surgery, in an African country. And also, when I was at Vanderbilt, there's a nurse who went to Africa and took pictures of an inpatient in a psychiatric floor. She came back with that trophy and was trying to advertise it. And when I asked her why she did it, she said because the young man wanted to come to the United States, and she felt she could do it. With the medical student who said he did surgery in an African country, he would probably exaggerate what he did. But those two cases illustrate some dimensions of issues relating to humanitarianism and ethics. I've tried to suggest that when for an activity to be seen as a global mental health activity, that we should look at the dimensional aspect. We should also look at the criteria aspect. The dimensional aspect will be, what are the historical relationships between the donor and the recipient? What are the economic issues? What are the political issues? What are the sociocultural issues? Some people have suggested that global health is about to die off because it's been overtaken by cultural psychiatry. And I say no, because global activities have a context, and the context is cultural. And so the cultural aspect remains a fundamental aspect of globalization as well as global health. Now, the criteria issue for me is that for any program to be seen as a global mental health program, there should be a universal interest like poverty or stigma, or there should be a public health component like violence. The stakeholders should involve individuals, institutions from at least two countries. And there should be a problem ownership by the recipient country. And the solution should be undertaken by a team. This implies you have a multidisciplinary team, social workers, economists, and so on. Yeah. So what are some examples of potential minefields in global mental health? One area is that there's a question as who's going to determine the priority? Who's going to do the planning and monitoring of foreign aid? The Organization for Economic Development in 2005 came up with some parameters. There should be ownership. Developing countries should set their own strategies for poverty reduction, improve their institutions, and tackle corruption. There should be alignment. Donor countries should align behind those objectives and use local systems. There should be harmonization. Donor countries should coordinate, simplify procedures, and share information to avoid duplication. Developing countries and donors should shift focus to development results, and results should get measured. And there should be mutual accountability. Donors and partners are accountable for development. You see that with this background, there's an attempt to decolonize these arrangements. Now, SOPCO was in Afghanistan, and he was responsible for Afghanistan rehabilitation. And I heard him talk once, and he mentioned some points which I've described as being part of a template. One, does the project or program make a clear and identified contribution to national interests or strategic objectives? Does the recipient country want or need the project? Has the project been coordinated with other donor implementing agencies, the recipient government, and other international donors? Are security conditions favorable to effective implementation oversight? Are there adequate safeguards to detect, deter, and mitigate corruption? Corruption is a major issue in terms of international aid. Does the recipient nation have the financial resources, technical capacity, and political will to sustain the program? Sustainability is also a major problem. When a country or an outside agency is given a grant, for example, the donors want a quick result. And some programs have to take many years for the results to be seen. But sometimes they put pressure on the recipient countries, or the program may be terminated after a year or 2 years. And we have plenty of examples of that right now. Have the various stakeholders established meaningful and measurable metrics for determining success? So there should be an assessment of outcomes, and there should be monitoring of projects. World Health also has guidelines. Some of these guidelines are in epidemics, emergencies, and disasters. And there are ethical standards and procedures for research too. So what are some missteps in terms of these activities? Okay. Some pharmaceutical practices are questionable. Now, 70% of the world lives in low-resource countries and manufacture only 7% of what it uses. Some pharmaceutical companies are known to dump expired drugs. They're also corrupt. There's a major example in 1990 by Pfizer. Pfizer is one of the top world pharmaceutical companies. In 1990, in Kano State, Nigeria, they were developing an antibiotic, I think it's called TAV1 or so. They went to a field hospital and gave children who had meningitis a drug that was not approved by the FDA, no informed consent. The informed consent was forged a week or so later after the study started. Pfizer said that there was informed consent, verbal consent given to the nurse in charge. And this led to a protracted case that was held in New York, and Pfizer was found guilty. I don't believe they ever apologized. So there's also always the question of the informed consent in developed countries. Does it have the proper language? What's the role of elders? And what's the age of consent? There were also some missteps in HIV/AIDS research and treatment. In one study, for example, to look into vertical transmission of AIDS from pregnant women to the children, the wrong dose was given to some children, or on the broader scale, there were countries and women and patients who never had access to anti-AIDS medications. In some cases, children were given less than recommended doses of medications, inappropriate medical record keeping, lack of proper use of control subjects. What about education and training? I mentioned to you the case of the young man who went to Africa and said he did surgery. In the United States, for example, in Europe too, all over the world, there's considerable interest in overseas experiences. Global health has become an avenue for professional development and professional growth for a variety of reasons, that they can give a broader view of the field. And a number of residency programs have foreign affiliation. There's opportunity for comparative and contrasting exercises. But then there are some ethical issues in terms of what about resource allocation? The lack of medication in some of these places, the practice of confidentiality, which may vary from place to place, and treatment approaches, and cultural variation in the role of families, and practicing outside certification and skills? What are the specific expectations of somebody from the United States going to Kenya, for example, to be an investigator? What are the elements of cultural behavior and etiquette? I remember at a conference in India many years ago, a friend introduced his wife to me. I tried to offer my hand, and she wouldn't take my hand. And I think I made that mistake again recently with a Muslim woman. What's an adequate curriculum on supervision? We talked about the cultural norms around gender and the need to be familiar with professional codes of different disciplines. With the case of the young man who said he performed surgery, was he briefed before he went abroad, or was he debriefed when he came back? We talked about who sets the priority and who funds projects and so on. Again, low-income countries account for about 50% of global burden of diseases, but 2% of global spending. There are countries that have less than 10 psychiatrists for the whole population of millions, 20 million, 30 millions. And as I mentioned before, in 1970, there was a UN agreement that the rich countries should give 0.7% of the GNP for overseas aid. Many countries do not observe this goal. The countries that seem to observe this goal are Sweden, Norway, Finland, and so on. In terms of absolute contribution, United States usually contributes the most. But in terms of percentage contribution, United States comes about 24 in the ladder. But if you ask the average person on the street how much the United States contributes to foreign aid, they probably say about 25%. But in fact, it's less than 1%. For defense, it's about 18%, and for the rest, it's about 80%. So we have misperceived notions as to what constitutes foreign aid and how much. There are some individuals who've built their career and taking pictures of people who are mentally ill. And the reason they give is that for advocacy, humanitarianism, photographs are used. It's as if there's a quid pro quo, and people have trophy photographs. I think this is a terrible practice. Do unto others as you'd like to be done to you. I did mention the question of AIDS research. Examples of pharmaceutical mishaps, again, includes clinical trials of AZT on maternal child transmission of HIV, inappropriate use of informed consent, the need to involve the community and local leaders, the need for privacy of information, fair sharing of data and publications. This is a very strong issue because my colleagues in Africa are upset that people come from abroad to partner with them to do research, and at the end, they don't have any participation in the data. And another issue is the brain drain. It is estimated that 27 to 30% of physicians in the US, UK, Canada, and Australia are international medical graduates. There are many reasons for this. One is because of the colonial history. If you came from a British colony, for a long time, the only opportunity for you to get advanced degree or advanced training is to go to England or Scotland or somewhere. But then circumstances change, and you have to decide whether you want to return there back home. I did see, when I was in London, I saw a memorandum that was asking that consultants should encourage the residents and registrars to return home. You know, but what do you do if there's a civil war in your country, or how you're going to give your family the best opportunity. When I was in Edinburgh, it was the time when kidney transplants was becoming popular, and if you're in an institution, you want to be treated like everyone else, and not to be discriminated against, and so on. You know. The AMA perceives that about 17.3% of 2/3 of people were IMDs were trained in Nigeria and South Africa, and that there's been some growth of psychiatrists in the world, but these growths are not the same. Like in England, there was growth of 5.9 per 100,000 psychiatrists. In the UK, in 2003 to 7.4 in 2014, whilst in Africa, the growth rate was only 0.1. So that's different suggestions to reduce brain drain. One is to encourage postgraduates to return to their home countries, but then there's a question of individual autonomy. Another is for the home governments to ensure that you have national service. This is like in Israel, where there was a time when you couldn't go abroad for 2 years to work. And then the United States had restricted visas. And South Africa has stopped recruitment from sub-Saharan countries. So what's the future of global mental health? There's been some activities in this area, but as long as there continue to be some activism and with a role of civil society, with patient advocacy and self-directed therapies, with users, survivors, and their family and friends, I believe there continue to be a place for global mental health. Hopefully there'll be a reduction of stigma and exclusion, and this will also help. Self-help and country ownership should contribute. There should be a change in perception. With the change in perception and definition of health and mental health, that will help. And also, climate change, food and water security may help. And integration and implementation of research, policy, and services may help. Telemedicine, telehealth, and technology. There was a fear initially that globalization will result in the major corporations and conglomerates taking over the role of national governments and so on. And Hess and Thompson, two economists, looked into that and came back and said, no, that's not likely. You know, now economists are very reluctant to make any prognosis, because a simple event may go a long way in changing the whole map of things. Take, for example, the changes with the US aid. And it's remarkable because PEPFAR, that controlled billions of dollars and so on, and many grants, that has been abolished. Some drugs that were very expensive have been destroyed. And US aid had considerable memory and knowledge about foreign aid and dispensation of grants. And US aid did not only distribute US government money, but also helped in implementing programs for NGOs and so on. Ken and Najam are two economists from the Boston area. They were recruited by some faith-based organizations to look into this issue as to what will be the future of globalization. They used a scenario analytic approach for analysis of complex systems. This is a recommendation by the UN. They looked at scenario analytics is used mostly in systems where there's some surprise element, there's ignorance, and there's violation. Okay, they identify some driving factors like information and communication technology, the behavior of markets, probability issues, and policy orientation, and apply this to domains of exclusion, inequality, and human insecurity and health, and cultural and social environment, institutions and governance. And they came up with three scenarios. The first one was the global marketplace. This is governed by free market and political thinking. And the next one was managed planet, which is governed by dominant policy issues. And the last one was the first rest world, which is a break from the then current value systems and policy institutions. They recommended that the most desirable would be a combination of global marketplace and the managed planet, citing that the fortress world, which is a break from the then current value systems, will result in autocracy, marginalization, and poverty. And they recommended that the major institutions, NGOs and so on, develop dominant belief systems. And they should become policymakers and entrepreneurs. They should utilize advances in ICT technology to influence ICT policies. So in conclusion, what may be the future of global mental health? What are the challenges and opportunities? As we said, we hope there will be increased activism in civil society by advocates, users, and survivors. And in contemporary times, the lived experiences is becoming very powerful. And I went to a conference once when I saw some people very disabled participate in programs and take strong stance in policy issues. We anticipate that there continue to be some WHO agreement. And if any major country decides to be unilateral, that would be a threat to this idea of being together and in one. And hopefully the impact on international mental health agencies will be minimal. Now, the next one, reduction of stigma and exclusion and disability reduction, is significant. Families and patients and advocates are doing their best to reduce stigma and exclusion in areas like in autism and so on, but it's not an easy task. And hopefully there'll be a change in perception and different definitions of health and mental health and quality of life. The issue of human dignity remains an issue. There should be global ambassadors of health. The issue of social determinants of health, poverty and stigma are perhaps major barriers to mental health. There are problems with immigration. Immigration itself is a risk for vulnerability and so on. Human trafficking, civil and international conflicts and violence, all these are likely to affect the future of global health. Climate change is gaining ground, and also immigration, water shortages, and food shortages. There are greater implication and integration of research policy and practice. There's a move to integrate mental health services into primary care practices. This afternoon, 2 drug reps came to my office, and they said that they find out that the primary care doctors have to treat a lot of depression because the patients complain of sinusitis, but by the time the patient leaves, what they complain about is depression. There's a belief that anxiety and depression in society is increased, especially for young people. And we hope that telemedicine and e-health and of course AI is a major issue right now. It has its potential advantages and perhaps also risk. And there's some suggestion that AI may actually result in psychosis. And so there's need for regulation and need for monitoring. So I'm going to stop here, and perhaps we can have some discussion or questions. Thank you.
Okay, thank you so much, Dr. Okpaku, for a really wonderful, wide-ranging and thoughtful talk. Enjoyed that very much. And thank you for allowing time for questions. So we have a good bit of time. Feel free to put a question in the chat or raise your hand. And I see one hand up already. Miriam, do you want to ask a question?
Yeah, thank you so much, Dr. Okpaku, for the interesting presentation. I just wanted to take the opportunity to ask, given your extensive experience with ethics and global health, do you think poverty is something that we can end, or do you think it's inevitable that it'll, be an issue forever?
I'm an optimist. Well, I think people believe that if the United States wants, they can end poverty in the world. And as I said, in my conversation with the father of a student who worked with me for some time ago, how many beds can you sleep in at one time? There are some people who are so wealthy they can buy the whole of West Africa. What are the benefits of that? So I think Winston Churchill said, it's not for us to fathom the inscrutability of nature, but I say it's not for us to fathom the inscrutability of human behavior. But there are some nice people, some good people. It's always interesting to see how you have some wealthy people donating 90% of their wealth to charities, or to see Bezos' wife give much of her money to charities and so on. We have to continue to try to strive, and developing countries and recipient organizations should do their best to become self-sufficient, so they're not exposed to further colonial enterprises and abuse.
Thank you.
Thank you.
Again, feel free to just raise your hand or put a question in the chat. I have a question for you. I think through your talk, I mean, explicitly and implicitly, you made a number of suggestions regarding, how government policy could, enact a more thoughtful, humane and ethical treatment of global mental health and help for less resourced countries. What do you have any? I think we're part of two audiences here. One is part of a local public mental health department. The other is part of a local academic institution. Would you have any suggestions for how either an academic institution or a local, like, county mental health agency could contribute to these challenges?
I think first and foremost, the academic institution should have a foot in the non-academic institution, and it should be both ways. In other words, in the Philadelphia area, for example, when I was there, Penn was involved in certain programs, but I found that Temple was probably more relevant. Hanneman was probably more relevant. And as soon as Penn lost the grant, then services were over. I think the residency programs should make it mandatory for people to have experience from all sides, and so a good educational program should take into consideration. Penn, for example, also was dealing with Philadelphia General, which was a community, or more or less, for individuals and for the military guys. So these are policy issues. Policy issues should be humanitarian, and the departments should have an interest, and should stimulate interest in providing service to all segments of society, and providing service to the poor should be a major enterprise for academic institutions.
Thank you.
We didn't have opportunity to talk about things like task shifting and task realm, and the opportunities for the North to get benefits from programs in the South, like the Friendship Bench and some other programs which are very interesting. So how can we use our resources to the best of our ability? How can they say there's some very interesting programs in Africa that can be used now in the United States. For example, look at Rwanda. The issues of forgiveness is such that it has been adopted by the Episcopalian Church. So we should strive to look at opportunities to use experiences from other cultures and situations.
Hi, Jamil, you've got a question. Go ahead.
Yes, thank you for your talk. I had two questions, but I'll just start with one. So the first one is we have somewhat of an epidemic here in the States around loneliness, and particularly among men. And I'm wondering if, in your experience, you have come across programs or policies outside of the US that have addressed this issue, if it's even an issue in other countries.
Okay.
Yeah.
I was in Japan 2 weeks ago for the WACP, World Association of Cultural Psychiatrists, and the Pacific Rim. And Noma Soteros, who was head of WHO, was talking about this issue. Now, I come from a family of 9 people. One of my sons has only one daughter, and the other has twins. Now, when I was growing up, we all went, most of us were in the same compound. You have grandparents, you have uncles, you have aunts living close by, Human beings are social beings. If we're feeling depressed or isolated, just having a conversation with somebody else will improve our temper. I know when I was studying in England, for example, some people went to the library in the winter for heat and also for companionship. I go to the YMCA in the morning, and some people go there because they need human contact, So I think a program like Holland, for example, is attempting some programs to deal with this issue. And I think the churches can do a lot in this direction, and I think we should promote less reliance on the internet, as it does not really erode the consequences of loneliness. So we have to devise and stimulate organizations for loneliness. I don't know what your colleague Philip Gister thinks about reducing this problem. It's a big problem. So, do you have any thoughts? Hello.
Or sorry, who are you directing the
questioner?
Oh,
Do I have thoughts around how to address loneliness?
Yes.
Yes. I agree with your assessment of the internet being a major culprit. I also think there are other structural issues that contribute to loneliness, one of which being the cost of living, and just economic inequality that forces people to be separated from their families and forces people to work multiple jobs, that keeps them from their kids, keeps them from their families. So I think that's one major one. I also think that there's like I'm reading this book. It's called The Friendship Bench. You might be familiar with Dixon Shabanda, Dr. Dixon Shabanda. He's a psychiatrist out of Zimbabwe. And
Yeah.
he's been using grandmothers in parks as ways to address the loneliness and depression epidemic out there. And that's, I wouldn't even call it an epidemic. I would just say the issue of depression. And so I think maybe even being sort of innovative in how we use promotoras and community health workers in the States, and making them more accessible to sort of like be those companions that you're speaking of.
That's very true. Also, there's a program in Uganda that uses grandparents to treat adolescent kids who have drug problems and so on. And so that friendship idea is spread in many places. Now, one reason that grandparents live is because of their grandchildren. You know, so that I think in Holland for some time there are programs to bring grandchildren. They don't have to be biological children, you know, to provide companionship for grandparents. I think there's another epidemic, is the tension between granddaughters and their grandmothers and their mothers-in-law, granddaughters and mothers-in-law. When young women had 5 kids and they needed help, grandparents were useful. Now that some women are choosing not to have children, have 1 or 2, they probably not need as much help as before. So a restructuring of family ties may be helpful, and education and the use of artificial relationships to compensate for the loss, I suspect will be useful. I think churches and religious and NGOs have an opportunity to use this, to do something about this.
Thanks a lot.
Thank you. I suspect that some of you have had experiences as students or residents in developing countries. What has been your experiences? What about people who've been to West Africa, to South Africa, and so on?
I have an answer. I think I grew up in Egypt and I saw how much need there was in my country, and I think oftentimes we think about people who are very rich donating to poorer countries, but we don't see like our personal responsibility to do that, because sometimes somebody's biggest issue is just like $5. So I thought that's like something interesting to think about, is not just asking people who have so much money, but also trying to move to a culture where everybody feels a certain responsibility towards that.
Mhm. Yeah, I agree with you. And I think also in a place like the United States, there's so much division. Like in some African countries, the poor and the wealthy live close to each other. You know, and you don't have this big separation with Beverly Hills and then other places, you know. And in some areas, you know, if you drove into the area, they ask you if you are lost.
Hi, Dr. Okpaku. I'm Naomi. I just wanted to speak to your question that you had raised recently. I grew up in Nigeria as well, and I think with the topic surrounding mental health specifically, when I was growing up, it was kind of something that we kind of convince ourselves that it's a Western problem. And I think moving to the US now, I really discovered how important verbiage is in articulating or like conveying certain things. Because I think back to people who were around me, and maybe they didn't say the word depressed because that's a Western term, but I feel like there were other ways for them to kind of like express that they were struggling with something that is the exact same thing as depression without calling it depression. So I think like now I realize even more how like these quote unquote like Western mental health issues actually diffusely like exists around the globe. We just have a different way of expressing it. And I think it's just like always been there. And it's not like necessarily like a new age problem. And so yeah, I think just coming to terms with how like, you know, I think back to like my neighbor who would come really late and like was always drunk. And I think, oh, he actually probably was struggling. Or I think to people dealing with like financial losses or losing like how their affect would change after they lost their jobs or lost like a family member. And now I think back and I'm like, that person was probably dealing with grief and was probably depressed. We just didn't call it that. So
yeah, you make some very interesting and very good points. Also at this conference, Noma Soterios made some comments about the pilot study of schizophrenia that showed 60 years ago that schizophrenics in developing countries did better than schizophrenics in developed countries. Okay, so what is it about developing countries that is more acceptable than what happens in Western world? And in Los Angeles, about 20, 25 years ago, there were people who were interested in express emotions. And they were emphasizing that, you know, when you discharge a schizophrenic to the home where there's been a lot of hostility, it's likely to get worse. So tolerance varies across cultures. The definition of illness also varies across cultures. The acceptance varies across cultures, you know. And society is becoming more complex, you know. And if you're going to discharge people who are psychotic, you make sure they have suitable environments where they can be well taken care of. In developed countries, you need to get insurance. If you don't have insurance, you don't get good treatment. And for you to have psychotherapy, you should have transportation. You know, so all these social determinants of health are significant. You know, and family practices vary, and accessibility to grandparents is very important. And in a large culture or country like this, where distances are far apart, you know, I have a son in Texas, another son in Philadelphia, and live in Nashville. You can imagine if all of us were living in the same city on the same block, that would be a different experience. So, but you know, I think mental illness is very self-evident. Human suffering is self-evident. No matter how much we try to conceal our feelings, you know, talking about the use of certain words. I saw a man yesterday because I have a contract to see veterans applying for benefits. This man is 60 years old. He has cancer of the prostate. He has lymphoma. Wife just had surgery for back injury. And I said, why are you coming to see me? And I said, the VA sent me here. How do you feel deep down? I'm happy. I'm happy. But he's sad. The military guys I see never say they're sad. They say they're anxious. So I say, okay, I'm giving you 4 options. Sad, happy, irritable, anxious. Which one or which combination best determines how you feel deep down? They never say they're sad. They say, I'm anxious. You know, so people have preferences as to how they want to express their feelings. And, you know, if you listen to Indian music, for example, or Persian music, which I think is very reflective, I think there's a basic element of sadness in some cultures, in their poetry and so on. And even in India, they have music for morning and evening for evening. In the Anglican church, you have the morning hymns and the evening hymns, which are somewhat different. So cultures vary in terms of expression of pain.
may throw in one more question. You'll notice that there's been a lot of interest, in question and comment from the younger people in this group. There's probably a good bit of desire to, for the trainees, medical students, residents, to get involved, to express, express their opinion, their social attitudes, and do something. What would you just suggest to the trainees here who might ask, how do I get involved?
Well, first and foremost, I think to say that they're interested, I think they should be supported as much as possible. And I think different generations emphasize different things. And people of my age and so on who went into psychiatry probably went in because we were interested in psychotherapy. There was Parker Bell, the music by Parker Bell, and so difference, and different groups have different interests. At the time I went to psychiatry, we were interested in literature and things like that. And I think right now people are interested in digital and so on. But I think they have to be supported to know that they are useful, and they should be encouraged to use their usefulness as and to be productive and to help. And but they should understand they have choices though, and that no matter what they do, it's useful. They should be encouraged to understand that they should write. They don't have to do any practical research to be able to write. They should understand that their opinions are important and that they're useful, and they should be accepted. So I think the department should expose their residents as much as possible, and make them have some confidence and pride in their own cultures, and to make sure that their opinions matter. Now, if we're talking about lived experiences, patients are telling us about the experiences, and we want to respect that. And I feel that every situation is a transcultural situation, and in transcultural situation, we have an obligation to listen to the patient. Similarly, we have an obligation to listen to the young ones. And as somebody said recently, is that we are educating away creativity. When we're young people can have creativity, look at problems from a fresh perspective than the elders who may have self-interest. So people should be encouraged to do some small projects, and should have, I think mentorship is very important. There are many different types of mentors, but mentorship should be available to everyone who's interested. And it should be an active process.
Very good suggestions. Speaking of young people, Michelle, you have your hand up too.
Oh, yes, thank you. Yeah, no, I've just been collecting some thoughts and appreciate everyone's collaboration. Just wanted to bounce back to a question that was asked earlier about like my experiences abroad, and I had the opportunity to go to Taiwan for a medical missions trip, and kind of bouncing off of I think Naomi's point with how medical symptoms are reported differently, at least in the Asian American culture. Mentioning emotions like anxiety or sadness oftentimes isn't even discussed, and if anything, we usually have a somatic presentation of sadness. So I've met a few Asian American presentations where instead of Asian American patients where instead of saying like they suffer from anxiety or sadness, they'll just say they have a stomach ache. But then when you dig further, it's that those somatic symptoms are like a physical, like I guess, portrayal of their emotions or a consequence of their anxiety that they're building up. And I just wanted to circle back to, I guess, a question I have for anyone on the call is, you mentioned the loneliness epidemic, Jamil, and I completely agree. I think social media especially has a big role to play into that. But it was mentioned that churches and religious organizations can play a role in that. My church has partnered up with like a church in Uganda actually to help like deliver medical missions trip But I'm wondering, like, outside of medical missions trip, for those of us who, may not have the time or the travel costs, to like go abroad, what are ways that religious organizations or churches can help, with the mental health epidemic that we see going on, or just loneliness in general?
Mhm, mhm. Well, Marian Weissman told me many years ago that you work with the population you have. And I think to be creative, you have to be curious. And to explore how you can contribute, Um, um, I think there's plenty of opportunity to help. There are organizations like the local Rotary clubs and so on, where people volunteer to do certain things. And people are curious, people are anxious, and suffering is pervasive, So, but, so I think there are plenty of opportunities to be helpful, to be needed. And as I said, you don't have to do any major, in terms of research, there's a single case history. You can write an important case history on one case, and so work with what's available to you. Make sure that your residency is active, and make sure they provide you with your wishes, and be curious and be confident in your observations.
Yeah, I think we have time for one or two more questions, and I see there's another raised hand. Or if I'm pronouncing your name right, but yeah, Yagana.
Yes, you got it. Hi, thank you for this amazing talk, and I really have been reflecting on what everybody else has said. So my family's originally from Afghanistan, and I've been there in the capacity of like a public health, global health student. And one of the things that kind of struck me was similar to what you mentioned. In the past, like social structure was such a protective factor, and intergenerational, multi-generational homes, having grandparents around, was such a strength for the Afghan community. And unfortunately, due to conflict and war and a lot of structural factors, that seems to have been heavily hit, and probably one of the first things that was heavily hit. And now as like I'm a medical student, I'm learning more about, psychiatry and kind of the medical perspective on things. I think I'm coming to the point where I'm kind of thinking about, what elements of reviving those original protective factors, cultivating that, as well as kind of bringing in the medicine and kind of newer curiosity approach. I think finding that balance is really interesting and something I've continued to explore. But not sure if you have any advice or any thoughts on kind of that balancing the protective factors and things that have kind of been tried and true, and trying to recultivate that in a very new world, which separates people, like everybody mentioned, through technology or different factors. Versus kind of being curious and trying to bring new thoughts into that space.
Well, you raise an important issue. I think sometimes as psychiatrists, we tend to live in an ivory tower. But if you go into the community, you find that ordinary people are doing a lot. Like I belong to a Rotary club here, and I discovered that a new program was just set up with people who are volunteers, and they're interested in a variety of things, like kids who have been committed for, who have been abused, or kids who have been presented at courts and so on. So you want to search your community and see where there's an opening where you could contribute. At the church I go to, they've adopted a school from South Africa. So I saw a vet today who has a group that meets every Tuesday at 1 o'clock. So there's plenty of opportunity, but you got to do something you're interested in. And I think all of us are controlled by harmony and balance. You want to have a balance in your own life, and but my advice would be to search for something that interests you, and as Minor Weissman told me, to work with the population that is available to me.
Okay, well, I think that's about time. Dr. Okpaku, Sam, we're deeply grateful that you gave your time and inspiration to the audience members in Harbor UCLA and UCLA School of Medicine.
Well, I've enjoyed this, and I thank you all for giving me the privilege to talk to you all. But I'm available if people want to ask further questions or they want to have some connections. I'll be available to help them with the connections.
Yeah, I can connect anyone to Dr. Okpaku if you'd like. Just let me know. Okay, thanks again, everybody.
Thanks a lot. Have a nice evening, all of you. Bye.